Next, we have Dr. Vasanth Stalin. He will be discussing cultural competency in bariatric surgery care. Where are we? What's needed? Optimizing culturally competent outcomes. And he is a general and bariatric surgeon with the Ascension Medical Group. Thank you for coming, Dr. Stalin.
Thank you to ASMBS, the panel, and Dr. Cook for having me here. This talk was originally supposed to be done by Dr. Johnson from the Morrow School of Medicine, but unfortunately she couldn't be here, and I appreciate the opportunity being able to present this instead. So I do not have any disclosures. Introduction to culture. So what is culture? Culture can be defined as the personal identification, language, thoughts, communications, actions, customs, beliefs, values, and institutions that are often specific to ethnic, racial, religious, geographic, and social groups. And individuals' cultural affiliations can certainly affect how and when they seek care and whether they are even going to follow your care recommendations. And moreover, physicians themselves bring their own cultural orientations, including into the culture of medicine. Ethnicity, gender, and race are important factors that affect culture, amongst other things. And cultural competence in healthcare refers to the ability of systems to provide care to patients with diverse values, beliefs, behaviors, including the tailoring of healthcare delivery to meet patients' social, cultural, and linguistic needs. Nowadays, it's also being used to encompass other groups, such as people with disabilities and LGBTQ community, amongst other groups. Cultural competency has also become intimately linked with health literacy, and this understanding calls for integration of cultural and linguistic competency with health literate approaches. The goal of any culturally competent healthcare service is to provide the highest quality of care to the patient, regardless of race, ethnicity, cultural background, English proficiency, or literacy. So obesity, we've already heard, disproportionately affects individuals from specific ethnic minority groups. Overweight and obesity rates are highest amongst the Black population. Even amongst children, as we have already heard, amongst the Hispanic population and the Black population, the numbers are very telling. And based on geography, especially in the Midwest and Southeast, the numbers are higher. And in nearly all states, obesity rates are higher amongst the Hispanic adults relative to non-Hispanic white adults. So it's important to recognize that in treating obesity, the largest percentage of individuals suffering from the condition come from a minority culture. And why is this important? By 2050, racial and ethnic minorities will comprise about 30% of the elderly population, and it is expected that 1 in 5 Americans will be elderly. As the population becomes increasingly diverse, more attention to linguistic and cultural barriers to care will become necessary. And racial and ethnic minorities also have higher morbidity and mortality from chronic diseases, and they are more likely to be limited with activity. They are also likely to have lower levels of literacy, and because of this low literacy levels, the resulting healthcare costs are higher, estimated to be as much as $58 billion, that's with a B, dollars. Given the fact that the most affected by obesity in the US are members of ethnic minority groups, one would expect that the demographics of bariatric surgical procedures to reflect these proportions. However, the reality of bariatric surgery numbers suggests that Blacks and Hispanics constitute less than 10% of all bariatric surgery patients. Urban dwellers are 4 times more likely than the rural population to have the surgery. Females are 4 times more likely than males to get the surgery. And ages between 40 and 59 were 1.5 times more likely than those of a younger age group, and 6 times more likely than someone over age 60. Anyone with insurance, private insurance, had a higher likelihood of getting the surgery. But most importantly, whites were twice as likely as Blacks, Asians, or Native Americans to become a bariatric patient. Hispanics were 20% less likely to receive surgery also. So this lack of cultural competence can certainly lead to patient dissatisfaction and poorer outcomes with bariatric surgery. Black women were eligible for bariatric procedures at twice the rate of white women, although they actually had surgery at just over half the rate of whites. Black men were 50% more likely to be eligible for bariatric surgeries, but had them at 1/2 the frequency of their white counterparts. Men, Black and Hispanics were more inclined to seek surgery if referred by their PCP, but such a referral was less likely in this population group. Although economics was presumed to be a significant factor in these differences, a significant reason that African Americans had not considered bariatric surgery was that obesity had not diminished their quality of life as much as it had diminished quality of life for Caucasians. Obviously, this is a cultural perception in that population group. And this was an interesting study that I came across, perceptions of perfection. Predominantly female representatives from 18 countries were asked to retouch this image on the right to fit in with their own cultures' perceptions of what they considered to be the ideal female form. And you can see how they've done the deed. You can see what the Italians did. And in the middle, that's China, UK, Philippines, and this is the United States at the end. So if you really went by this
different.
ideal, the BMI of the Chinese girl would be 17. The Italian would be 18. And this disparity, the level of motivation for a certain body type may vary dramatically, as you have just seen, based on ethnicity and cultural background, which may influence weight loss goals. Relative to Blacks, both whites and Hispanics tend to lose more weight following surgery, despite Blacks starting at a higher BMI. 2 years following a gastric bypass, white women lost more weight than Black women. At least amongst Black women, research has shown that despite higher obesity rates, Black women show greater acceptance of being bigger, feeling attractive despite displeasure with their weight, a strong cultural pull towards certain foods, and less social pressure for thinness. Another cultural issue proved to be reluctance to focus on their own self and instead to be more attentive to others within the family and to the extended family. Focus groups looking at Black women's perceptions of bariatric surgery have shown positive identification with being somewhat larger and the sense that bariatric surgery was a drastic last-ditch option. On a program level, it's important to provide outreach to ethnic minority populations, particularly since they comprise the largest percentage of obese individuals. This may also include providing informational seminars in different languages or being accompanied by a translator, meetings with PCPs in minority neighborhoods, providing information sessions out in the community itself, where actually the target population is more likely to attend, and educating medical professionals about the benefits of bariatric surgery, including minority clients. And providing targeted education with added nutritional support in one's native language appears to make a big difference in outcomes. Helping individuals, especially with the insurance, if English isn't their primary language, offers major benefits, and encouraging familial involvement is important in many cultures. It is essential also to have an awareness of one's own biases to be able to deal with cultural sensitivity. Be aware of cultural views of authority figures, varied gender roles based on the population, particularly when dealing with someone from a minority background. Medical terminology should be used appropriately with clarity. Try to integrate dietary recommendations with one's preferred food palette, and that can go a long way. Respect the centrality of religious food customs, such as eating a kosher diet in Judaism, following halal in Islam, avoid beef in Hinduism, and working with fasting holidays such as Yom Kippur, Shivratri, or Ramadan. Weight loss goals may vary due to cultural perspectives, and these expectations should be discussed before surgery so that the patient's goals and those of the bariatric team are aligned. These are certain strategies that can certainly use for improving cultural competence. It's an ongoing learning process. It's impossible for anyone to know everything about every culture. So focus on an approach that includes curiosity, empathy, respect, and humility. Even within a population group, things can be very different. If you look at Latinos, a first-generation immigrant from Guatemala is very different in their cultural approach as compared to a sixth-generation Mexican-American. There are numerous federal standards and guidelines. CMS Medicare also provides some plans out there for these folks. Health systems are finding that developing and implementing cultural competence is also a good business practice in this racial and ethnic minority population group. Language is certainly an important factor, and make sure that interpreters are available whenever possible. There are language assistance strategies that are advocated by AHRQ. Promotoras within the Latino community have really gotten a lot of traction in this regard. Cultural brokerage is again another buzzword that's important these days. And AHRQ has proposed something called the RED Toolkit that, when implemented, can deliver the RED, the population, this particular population can decrease readmissions and post-hospital emergency visits. Mm-hmm. So just be aware of using these particular terms in this particular group. Don't use terms like big boy bed, extra wide wheelchair. Use neutral terms like obese or bariatric. Do not, advocate, all these negative terms. Mm-hmm. Make sure that you protect the patient's privacy. It doesn't matter how the patients got there. Just be, cognizant of how we treat them. Bottom line, cultural competence is a process rather than the ultimate goal, and it is often developed in stages by building upon previous knowledge and experience. Thank you so much for the opportunity.